I am very excited to introduce you today. We have a testimonial before our main speaker. It's Bhavna Vastava. She is also one of our survivors for the Walk for Life this year, and she is also on the cancer board of the Caldwell Health Foundation with me. So, Bhavna.
Bravo.
Wow, this is a great room. So, I'm not a public speaker. As we all know, I am a breast cancer survivor. And I'm here to talk to you a little bit about my story. And before I begin, I have to tell you that I could not have done it without some people in this room. One of them is my sister Bonnie. She just happens to be here, and I told her you can either stay home or you can come because it may be a little bit hard for you, but hey, it's over now, and we're moving on. And Dr. Cromwell, who I only ever meet in dark rooms. And I'm naked. I almost did recognize you. I'm sure you feel the same way about me. So I was diagnosed last year with multifocal disease in my left breast. And I'm 46 years old. I have no family history, and I just happened to randomly feel a lump that I thought was going to be nothing but a cyst because before, a couple years before, that's what had happened. So I thought, all right, well, you know, I've been getting my baseline mammogram since I was 40, which is what you're supposed to do. And it's wonderful at Palmetto Health. It's quick, it's easy, it's relatively painless compared to some other things we do as women. So the day I felt the breast lump was like after a football game in the fall, and I thought, maybe a cyst, maybe something, we'll just go get it checked out. They'll breeze me in and out of there. Literally, they breeze you in and out of there. By the time I went to my doctor's office, within an hour, I was in radiology, and I had lunch plans, and they were messing up my lunch plans, and I just thought, okay, well, this will be done, we'll be set, and we'll move on. And my life changed that day. Not only did I have one, I had 2 sites in my left breast, and Dr. Cromwell said to me, we're going to have to make some decisions, and you're going to have biopsies today. And I said to him, do you think we could not tell my husband just because he freaks out a little bit about things? And he looked at me and he said, do you remember 2 years ago when he came down here and decided he needed to look at the scans himself to make sure that it was all clear? And I thought, yeah, that and the ice packs on my chest are going to be a real giveaway. So we, of course, contacted him, and there's like a waiting period when you do the biopsies. And this is a really special place. I have to say that it was kind of an honor to be asked to speak here. Not only is this room full of friends, but my 24-hour waiting period was spent here. So they send your pathology off, and then you get 24 to 48 hours. Do you want to know what you do for those 24 to 48 hours until you find out whether or not you have cancer? Well, you call your friends and your family, and you just huddle up, and then you go to Bible study. And you sit in the room, and you know what's going on, but nobody else knows what's going on, and you're not sure. So you wait. So I waited in the sanctuary, and I came, and they had a wonderful, wonderful lesson. And I'll never forget it. It was about God's light shining through a broken vessel. And I knew I had cancer. I knew I was broken, and I knew God's light was going to shine through me, and He was going to give me the ability to stand up here and talk to you about how important it is to get yourself checked regularly, to be screened, and to do self-exam. I don't care what anybody says, self-exam is the key. I'd actually had a clear mammogram in December and found this in August. And it's that important because you talk to so many people. How do you find it? Some people pick them up with routine mammograms. Some people pick up things that don't look right on a routine mammogram, but you have to know your body. If you know your body and you know there's changes and you're at that age and stage of life, then this is the best healthcare system in the world. It is all here for you, and you have to reach out there and utilize it. Utilize wonderful physicians, nurses, and staff at Palmetto Health, whoever your healthcare provider is. Just know your body and don't double think. I think that's what another thing I've learned in Bible study is know yourself and know that voice, and it's taking you somewhere for a reason, leading you somewhere where you need to be. And I'm really the lucky one. I had stage 1A disease, had bilateral mastectomy with immediate reconstruction, and I had multiple rounds of chemo. But there's some people in this audience who have had so much worse. And I think now when I go in a room, I think I was a compassionate person before, but now I think I'm an empathetic person. I know that there are people in here who have family members that are going through cancer, going through degenerative diseases, have children that are not going to get better. If you can use the healthcare system to your advantage and you can use your community, you can do this. I did not cook for months. I did not drive anywhere for months. I had people like Bobby Curtis and Doug Bridges and Stevie Johnson and Cha Sullivan baking me things, feeding me, taking me, lifting me up constantly. And so this is a battle that can be won, but it takes everybody working together and your support. And we're getting ready to have a really big event. October 18th, we're going to have the Breast Cancer Walk, and we're going to have 9,000 to 12,000 people out there walking, and all the proceeds are going to go towards breast cancer research. And I hear we've got 3D digital mammography, which is something that probably could have really helped me, but it's going to help somebody else. So I just want to encourage you all to come and sign up. My team is Bottomless Bosom Buddies. Come join on my team, have your own team. Just come out there and be there and support us. Thank you.
Next on our list is Dr. Caldwell. He is from Pitts Radiology. Pitts Radiology has been serving Columbia since 1923. I did not know that until I looked it up on the website today. Dr. Caldwell he joined the practice in 2006. He specializes in women's imagery. He graduated from Augusta State University, and his medical degree is from the Medical College of Georgia from Augusta, and his postgraduate work was in women's imagery at University of Pittsburgh and McGee Women's Hospital, and his radiology residency was at Case Western Reserve University and Metro Health Medical Center. So please welcome Dr. Caldwell.
Thank y'all for the opportunity to speak with you today. And Bob, I do remember you, but I especially remember your husband. Cozy fellow. So the topic that I wanted to talk to y'all about.
Doc, you gotta stay close to the mic.
Okay, how's this? So due to technical issues, I may have to turn around so I can see what to say to you. This computer is not hooked to that projector. So at any rate, what I want to talk to you about today is a little bit different than the usual kind of breast cancer lectures in which we show you nice technology and how this finds new cancers and things like that. What I want to talk to you about is controversy, because there's been a lot of it surrounding breast cancer detection. So I titled this talk here, Complexity, Confusion, or Conspiracy. I'm going to put the information out, and we can have a conversation about it, but you decide. I think either one of these things is legitimate. So the objectives here, I just want to highlight the role of imaging in breast cancer detection and evaluation, discuss the limitations of breast cancer screening, and there are limitations, as we have already been alluded to. And finally, unpack some of the confounding issues in the literature. Different studies saying this, different studies saying that, different societies making different recommendations about who should be screened and how often should they be screened and when should we stop screening. There's some real issues that are necessary to discuss, but I think we need to consider how and in what tenor we're discussing them. Before I go too much further, I want to say these observations are my own. I don't intend to be representing my group or kids radiology or common health or anybody else. These are my observations and my opinions based on the things that I see. And so please don't take them any further than that. So let me start with a little overview about what breast cancer is. First of all, it's very, very, very common. You hear the often quoted statistic of 1 in 8 women in their lifetime. That statistic is artificially elevated. What you really see is that breast cancer is more common the older you are. So in young women, say in the 40 to 49 age group, it's only 1 in 69. When you take the entirety of a woman's life, it is 1 in 8, but that's over all age groups. So you understand how the statistic can seem artificially inflated. These are breast cancer incidents according to SEER data. These are national available data online. You can get them. According to SEER data, the incidence of breast cancer since about 2009 has been relatively stable, but increases at about 1% per year. The two lines that are overlapping one another you see here are white women and all races combined, and then the black women is represented by the red dotted line. And you see that the incidence of breast cancer diagnosis in black women has increased, but parallel to that of white women in all races. So I think this makes a point that is driven home by this slide, which is the mortality rate of black women, however, is much higher than all races and white women. So even though black women have fewer breast cancers than white women, they die more often. So why is this? I don't think that is related to limitations in access to health care or access to imaging. I think it's related to genetics. Black women simply have worse cancers, and therefore they die more often from them. Let's see. I think we're way behind the slides. So here we go. I keep forgetting and changing. My computer doesn't change that. So let's go back. Turn this way. So here we go. All races, white women, black women here, and mortality. It's not changing. Can you go to the next slide? There we go. We just have to be verbal about it. So this slide shows that black women die more often, that their mortality is higher than white women. So that's the point of those graphs. Next slide. So this slide here shows the age-adjusted mortality from breast cancer dating all the way back to 1975. And what you'll see is the breast cancer mortality was rising, and rising steadily until about 1992. Well, what happened in 1992? And the answer is widespread availability of screening mammography via the MQSA. So did we not have good medicine in 1985, 1990? Sure we did. We had chemotherapy and all these things. But what really changed the deflection, what really changed the trajectory of women dying of breast cancer was the institution of screening mammography. And upon this point, no one really disagrees. So what is a mammogram? Of course, you take the breast tissue, you take an x-ray of it, it looks kind of like this, it's very schematic. This is an actual mammogram of a real person. So you see that the tissue is represented basically in black and white. Interpreting these things is very difficult. It's hard to see through the breast tissue. But what breast tissue is basically glands and ducts. Okay? The glands are represented, if you go to the next slide, please. The glands are represented by, could you go to the next slide, please? Thank you. These little frond-like structures here, these are the ducts that transport the product of the gland, which is milk, transports the product of the gland to the nipple surface. So, next slide. So this is what it actually looks like histologically, where it's the same thing. You see the ducts, you see the glands. Well, these tubules right here are called the terminal duct lobular units. Go to the next slide. And the terminal duct lobular unit microscopically look like this. Again, we have ducts, we have tubes. We're continuing the magnification process where we have these cells lining the tubes and individual cells. So the next slide. So if we kind of go a little bit further into the process here, a little further zoom, if you will. So here's those individual layers of cells. Some are normal, they become abnormal, they begin to grow. Here they're confined by what we call the basement membrane. This is what we diagnose as in situ disease. Once the basement membrane is transgressed, now these cells have access to the lymph system into the bloodstream, and we get metastatic invasive breast cancer. So that's what these things are. Next slide. But we have to be careful to keep in mind that breast cancer is highly, highly, highly variable. There are no less than 10 different kinds of breast cancer. And what we call in situ disease is not necessarily in situ. What we call ductal is not necessarily ductal. It's confusing. It's a nomenclature problem. And the same thing with lobular versus ductal. Some things that we call lobular cancers don't come from the lobule at all. They come from the ducts. And vice versa. Some things that we call ductal cancers don't come from the ducts. They come from the lobules. So this is all very, very confusing, and we need to do more research. What we risk is lumping all these different kinds of breast cancers into one big giant box and calling it breast cancer and treating it all the same. It's not. It's very, very complex. It's very heterogeneous. So how are we going, next slide please, how we go about finding the breast cancer is screening or diagnostic. Screening is basically asymptomatic women. Diagnostic is you have a problem, maybe you found a lump, maybe you have a puck ring, what have you. And the only point I want to make really is that these are the same exam really. The only difference is the presence of the radiologist. So if the radiologist is present to evaluate them then and there, diagnostic mammogram. If the radiologist is not there, it's done offline. Screening mammogram, pictures are taken, interpreted later. They're not a different test. But when we interpret a screening mammogram, we decide which patients need to come back for some additional imaging. We call that recalls. We'll issue a letter to the patient, we issue a letter to the doctor who wrote the order, and there is a relationship between recall rate and breast cancer detection rates. In other words, if you recall lots and lots and lots of things, you find lots and lots and lots of cancers. On the other hand, if you recall very few things and only recall those things that are obviously cancer, then you miss the subtle ones. So if you're recalling very few people, your recall rate of 2%, you would have a sensitivity or a detection rate of 65%. But your positive predictive value would be fantastic because you're only calling back things that are obviously cancer. Vice versa, if you have a very high recall rate or higher, 13%, your sensitivity is 80%, whereas your positive predictive value has suffered. So you found more cancers, but you weren't as sure because you saw subtle things. So we've determined that the optimum rate is somewhere around 5-6%, somewhere in that neighborhood. And I want to make the point here that mammography saves lives, period. We all agree on this. Even detractors of mammography will agree that mammography saves lives. It reduces mortality from breast cancer anywhere from 15 to 30%. And even the detractors of mammography will say the same thing. The U.S. Preventive Service Task Force guidelines in 2009 that recommended this every other year screening showed in their data a 15% reduction in mortality. No question, mammography saves lives. So the U.S. Preventive Service Task Force said that in women over age 50, the number needed to screen to save one life was 1 in 1,300. Yes, upvote, right? Number needed to screen for women between age 40 and 50, 1 in 1,600, downvote. So again, someone is making some arbitrary decisions about what number is needed to screen that we're going to accept. Okay? Understand, mammography saves lives, period. The U.S. Preventive Service Task Force in their 2009 controversial recommendation wanted to make sure that we stressed the harms of mammography. And this is a screenshot off their webpage, and you can't read that, and I can't either, so I retyped it for you. And included some highlighted words here. And I want to take the time to read it to you. I know it's annoying when people read to you, but here we go. So it says, the harms resulting from screening breast cancer include psychological harms, unnecessary imaging tests, and biopsies in women without cancer, and inconvenience due to false positive imaging results. Isn't that kind of saying the same thing? Furthermore, one must also consider harms of treatment from cancer. Well, mammograms don't treat cancer. Mammograms detect cancer. So why blame the mammogram for over-treatment? Okay? Here we have what's known as well as the harms of unnecessary treatment of early breast cancers that would not have become clinically apparent, but would not have shortened a woman's life. They say that radiation exposure is a minor concern. Adequate evidence suggests that the overall harms of mammography are moderate in every age group, although the main components of the harm shift over time. So false positive tests and overdiagnosis and unnecessary early treatments are problems for all age groups, but the false positive results are more common for women aged 40 to 49. So the point here is that we're equating somehow more pictures with saving women's lives. We're putting these two things on the balance scale together. The false positive, meaning I called you back for some additional tests, for some additional pictures, is put on the scale with women's lives. That just doesn't make sense to me. It's not a moral equivalent. Whereas overdiagnosis is more of a concern in women for older age groups. I agree. Yes, that makes sense. But why not do mammograms in women who are younger if you know it's going to save their lives? Next slide. So, this task force, who is the U.S. Preventive Service Task Force? They're described as a panel of experts, but only one on this panel had any experience analyzing breast cancer data, and none of them had any experience in breast cancer disease. So none of them have any expertise whatsoever in treatment and evaluation of breast cancer. No radiation oncologists, no breast surgeons, no radiologists, no oncologists. So what are the experts in? They're experts in statistics. That's what they're experts in. They're masters of public health. They're experts in health policy, not in treating breast disease. So they have very little knowledge beyond that of a general physician. Next slide, please. So the U.S. Preventive Service Task Force, I want to depoliticize the issue of the task force. They were created in 1984. So the 2010 PPACA, the Obamacare Act, suggested that the Agency for Healthcare Quality and Research, or AHRQ, provides support for the task force. The director of the AHRQ appoints the 16 members of the task force who are volunteers. They're not paid. Okay? So who wants to be volunteers? People with passion, people with agendas, or people with connections. All right? And they have to be approved by an established, appointed director. The director of the AHRQ is appointed by HHS Secretary, who is appointed by the President. So the current director of the AHRQ, the guy responsible for appointing 16 volunteers, is a health policy expert. He is not a physician. He's not a doctor. He's a doctor, a PhD doctor, but he's a health policy expert, not a clinician. He replaced Carolyn Clancy, who is a doctor, and her area of expertise was internal medicine, and she resigned quietly and was replaced by Dr. Chronic. So getting back to the idea of harms of mammography and false positives, these false positives, as I see them, are really zombie bunnies. They're somehow horrible and hideous, but fluffy. I mean, there's nothing wrong with taking more pictures. So, what is it about patient perception? Next slide, please. What is it about patient perception that says taking more pictures is a bad thing? And the answer is patients don't care. They don't care about taking more pictures. 97% of them say, in a study done by my colleague at McGee, 97% of them say that women who have a false positive mammogram are not deterred from undergoing additional screening. In fact, 86% of them say, call me back more if you think it'll find more breast cancers. So this is not this is a made-up zombie bunny, false positives. Next slide, please. So why does the task force use the term false positive? It is scientifically correct. The term is accurate. But in common discourse, it's misleading. It's pejorative. It sounds nasty. And the lay people in the media don't understand this. They don't understand that false positive is a zombie bunny. So taking more pictures, once again, is somehow placed on the balancing scale with saving women's lives. The quoted false positive rate of 10%, for which the task force recommended, is equivalent to the same that you would see with pap smears. But there's no outrage about recall for pap smears. So what is it? Why is imaging so difficult? Next slide. And we're getting a little short. I'm going to skip this whole slide. The point of this is, if you really look at what the harms are, if you take 1,000 mammograms, only 6 will end up with cancer. You will do about 13 biopsies to find those 6 cancers. That return on your yield is incredible. It's 32% of the things you biopsy turn out to be cancer if you follow the rules and do things correctly. And that return is better than the yield if you just wait for women to have palpable masses and just biopsy palpable masses. Your return again is going to be 15%. Worse than if you use the imaging. So here's some of the studies. Next slide, please. Yeah, this is one. So here's a study that basically was published saying it costs $10 billion a year to screen for breast cancer. That was it. That was the study. It costs $10 billion a year to screen for breast cancer. And then another study comes out that says, if you follow the task force guidelines, which recommend half the number of mammograms, you only spend $3.5 billion. Okay, this is splashed all over the headlines. It costs $10 billion to screen. It costs $10 billion. We could save money. We could save $7 billion by doing the task force guidelines. Yeah, at what cost? We're putting this again on the scale of women's lives. What's the cost? The cost, next slide please, is 10,000 additional women would die of breast cancer if you follow the task force guidelines. What's the cost to our society for doing that? The additional morbidity, lost income, treatment of metastatic disease, $4.7 billion is what that's going to cost. If we follow the radiologist guidelines, you get a 70% improvement on the number of life years gained. The cost per life year saved is $75,000, well under any accepted guideline. More than 40%, this is a very important statistic, more than 40% of the life years saved doing mammograms is in women in their 40s. That's because they have a long life to live. We save them now, they live long. Those are the people we want to find breast cancers in. So, the government is spending money. This slide shows the pie chart of what the government spends their money on. As you see, Medicaid and Medicare are substantial components of their expenditures. And we need to do something about that. We need to have honest conversations about how to control these costs. Next slide, please. The Congressional Budget Office estimates that this is the spending that they're looking at. The solid line here represents now. Again, spending is only going up. Medicare, Medicaid on the top, and SCHIP, Medicare alone on the bottom. And what's causing this drive in spending? And if you read the fine print here, the Congressional Budget Office says key factors include the use of medical technology. It's medical imaging. Medical imaging is what's driving much of their costs. So, influential groups said we have to rein in the imaging, right? Crack down on doctors who order too many MRIs, et cetera, et cetera. Mammography is imaging. We got to crack down on imaging. These radiologists are making all the money. Okay? So they did. They cracked down on imaging. And then from 2006 to 2012, 12 separate laws specifically targeting imaging payments, mammography included among them, and the payments that Medicare paid out to imaging started to fall. It's exactly what they intended. Meanwhile, they increased spending and in turn, their numbers were up. That's what was intended. All right, next slide. This is to say that the publications that are publishing these papers are often physician trade organization papers, and I'm not trying to pit radiologists against everyone else or everyone else. I'm just being honest about what conversations we should be having. The Annals of Internal Medicine is a trade journal from the American College of Physicians, which is internists. Next slide, please. If you look at the salary gaps, radiologists are on the top of this, and internists and family medicine doctors are on the bottom of this. It's huge and growing. Is it necessary? Well, maybe it isn't. But if the thing is about money, then let's have conversations about money. Let's not have conversations about imaging. So, next slide, please. I don't know if there's any MTV fans. I'm almost done, I promise. I don't know if there's any MTV fans who watch this ridiculousness show. But it's a clip show that shows how people do stupid things and then they get to comment on the stupid things that people did. Well, I'm going to comment on some papers that were published. The Canadian National Breast Cancer Screening Trial. Women underwent physical examination prior to being randomized into the screening group or not screening group. Okay? So palpable masses could have been randomized into the screening group. In fact, they were. Turned out they were randomized to the screening group more commonly, and statistically significantly so. So what you ended up with when the data came through was there were excess breast cancer deaths in the screening group. Women who got screening mammography died more often of breast cancer than women who didn't get screening mammography, which is preposterous. How could that be? And in explaining this unnecessary bias, what they said was squeezing the breast squoze cells off into the bloodstream. Again, it's just preposterous. When they were confronted with this, they later recanted it. But of course, what gets splashed on the headlines is National Breast Cancer Screening Trial in Canada shows no benefit from mammography. These recantations don't get published. They're not sexy. All right, next slide, please. More ridiculousness. New England Journal of Medicine. Using SEER data from 76 to 78 to estimate the historic baseline incidence of breast cancer. 76 to 78. Go to the next slide, please. Recall this slide. 76 to 78 is this portion right here where breast cancer deaths were falling. Why were breast cancer deaths falling in 76 to 78? It's because in 1974, a sitting U.S. president and sitting U.S. vice presidents both had wives who had breast cancer. This increased the awareness. People went out and got mammograms. We weeded out cancers from the population, and then breast cancer deaths failed. So we're going to use this Texas sharpshooter point in history to establish a baseline, rather than publish baselines that have been available since the 1940s that are agreed upon at 1% per year. So in this paper, go to the previous slide, please. So in this paper, using the baseline estimate of 0.25% per year, they determined that that breast cancer incidence rates were not changing, and that the incidence of breast cancer deaths weren't any more significant, or advanced breast cancer deaths weren't any more significant. If instead they had used the proper 1%, what they would have shown was that there was in fact reduced mortality from breast cancer, and that there was in fact a reduction in advanced stage breast cancers. Next slide. So that same study also diluted women who had DCIS, again, not the same kind of cancers. And next slide. So Norway screening trial. Screening trial, they suggested that women hadn't been screened previously. Not true. They had been screened for many years in the private sector, just not in the public sector. And reanalysis after publication again shows that there was a reduction in breast cancer, but the reanalysis doesn't get published. And next number. So the definition of overdiagnosis is that screening leads to the detection of cancer that would never be clinically significant. So one paper suggests that if you screen people and the incidence of advanced stage breast cancers don't change, then you haven't changed anything by doing the mammogram. But again, anybody who works in this field knows that women who don't get mammograms are those who present with advanced stage breast cancer. They didn't randomize as to who got mammograms and who didn't. It is absolute ridiculousness, but it doesn't get published this way. Okay, next slide. And this is me ending. So what are the harms? False positives of 10%, is that harmful? That we don't reduce breast cancer deaths? No, we do. We do reduce breast cancer deaths. That we don't reduce them enough? Okay, that's a value judgment. That it costs too much money? Then let's have a conversation about money, not about the effectiveness of imaging. That it doesn't impact the incidence of advanced stage breast cancers? Of course it doesn't, because women with advanced stage breast cancers don't get mammograms. If you do get mammograms, you don't present with advanced stage breast cancers at all. that it leads to overdiagnosis. Again, we need to parse out what is the difference between overdiagnosis and overtreatment. Okay? Not all breast cancers need to be treated the same. Slash, poison, and burn, as Dr. Love likes to say. Not everyone needs that. We need to figure out who dies and who doesn't die. And finally, next slide. You know, reading a mammogram is very, very difficult, and I just want to put this picture up here. And does anybody see it? Horses. There are 5 horses in this picture. You guys see that? So, mammographysageslives.org. Go there and you can read about anything you want to read about. 1, 2, 3, 4, 5. Yes, ma'am.
I have like 2 or 3 things that come to mind. Number one, we need a better lobbyist. Because when I look at why people talk about the cost of radiology, it's usually advanced radiology, it's not mammograms. Number 2, if this happened to men, we wouldn't be sitting here talking. And number 3, if people really understood the cost of pharmaceuticals in Medicare and Medicaid, the fact that we're the only country in the world that doesn't negotiate those rates, and that you can have as many clinical trials as you need to eke out a positive impact of a drug that's going to harm more people than it helps, it's just ludicrous. It's just ludicrous. But first of all, I think you need a better lobbyist.
Well, the American College of Radiology has a very effective lobbyist. You know, mammography is regulated by the FDA. There's no other imaging that's regulated by the FDA. So we have reason to be involved and engaged with government organizations, and we are. The problem is that we're facing this monumental agenda on the other side. And when they look at evidence, the evidence is biased and is ridiculous. So how do you engage that?
I think we'll have to make it there. Appreciate that. Yes, thanks. Costs continue to rise, something we'll be hearing more about for sure.